So that looks like a good time to get started. Kia ora koutou, ngā mihi nui kia koutou katoa. Good afternoon from Wellington. My name is Carly Mercier. I'm Deputy Director of the Helen Clark Foundation. And welcome to today's webinar, which is called Beyond the War on Drugs, Reducing Harm to New Zealanders. So a particular welcome to new members or guests who are joining one of our webinars for the first time. If you're not yet a member and would like to support the Foundation's mission of responding to some of New Zealand's long-term challenges, we are currently offering a free tote bag to New Zealand members. So Victoria is going to put a link into the chat about that if you'd like to find out more. So we have an exciting research agenda this year. We have projects on infrastructure, climate change, agri-technology, the creative sector and social cohesion. And we look forward to updating you on those topics in the coming weeks. So to today's webinar, which we are co-hosting with the New Zealand Drug Foundation. We've worked on and off with the Drug Foundation for many productive years now on topics relating to drug policy reform and harm reduction. So it's great to have them alongside us today. First up, standard reminder that this is a webinar rather than a meeting, so we can't hear you or see you, so feel free to eat your lunch. No one will be able to see you. We would, however, love you to participate in the webinar. The best way to do that is through the Q&A function, which you can see down the bottom of your screen. So feel free to use the chat function to make comments about the webinar as it progresses or to introduce yourself. But if you want to ask questions of the panelists, you need to use that Q&A button. Our moderator today is the Right Honourable Helen Clark, and later in the webinar, Helen's going to put as many of those questions as she can to you guys, to our panelists. So the idea for this webinar came out of a partnership between Rose Crossan and the Helen Clark Foundation. Rose contacted us more than a year ago now to ask, with an idea, for a research project looking at how the New Zealand government spends money now responding to illegal drugs compared to how the public expects or would like them to spend that money. The idea being that hearing from the public in that way would help to increase the political licence to do the right and evidence-based thing, and to move away from a criminal justice approach to drugs and more towards a harm reduction approach to drugs. So I'm really looking forward to hearing from Rose about her findings, and thrilled as well that we have such a fantastic lineup of experts in this field today. Looks like Esther Tailfeathers has just joined us, which is fantastic. We also have Sarah. Good morning, Esther. Thanks for coming in from Canada. We also have Sarah Helen from the Drug Foundation. I'm going to hand over now to our former Prime Minister and the patron of the Helen Clark Foundation, the Right Honourable Helen Clark, who's going to moderate the session for us. As you may know, Helen's been involved with the Global Commission on Drug Policy since 2017 and also has been chair of its steering committee since 2020. So her knowledge of international drug policy issues is substantial and nuanced. So that makes her the perfect person to run the session for us. So over to you, Helen.
Well, thank you, Carly, and good morning, good afternoon, good evening, wherever people are beaming into the webinar. And as Carly said, I do have a little background on these issues, not least actually going back to being a Minister of Health a very long time ago. But since leaving UNDP, which was quite engaged in drug policy issues, we were one of the co-sponsor organisations of UNAIDS, and UNAIDS at one point agreed to set up a Global Commission on HIV and the Law, which was led by Mandeep Dhaliwal at UNDP, and Charles Chauvel was one of our commissioners at the time, with Justice Michael Kirby from Australia. We managed to produce a very good report on how the prohibitionist laws around the world were a great obstacle to meeting the health and human rights needs of people who use drugs. Now, when I left UNDP, I then became a member of the Global Commission on Drug Policy, and eventually its chair, and we continue to advocate against prohibition and for the sensible regulation of drugs according to potential for harm. So with that background, let me say that we were thrilled at the Foundation when Rose Crossan from Otago University agreed to be on our platform while she was on a sabbatical. to look at issues around public acceptance of harm reduction in New Zealand. And Rose is going to produce her findings shortly. Then Rose will be joined on a panel by Esther Tailfeathers from Canada, a change maker in Indigenous health, and we're very much looking forward, Esther, to your perspective. Sarah Helm from the New Zealand Drug Foundation, who has also been very much in touch with Indigenous approaches to these issues and ensuring New Zealand Indigenous voices are part of the conversation here in New Zealand and also in global settings. So, Rose, I should hand over to you first to do the briefing on the paper, which you produced while you were working on the Foundation platform. Over to you.
Thank you. Bear with me a moment while I pull up some slides. Great, thank you. So I'm Dr. Rose Crossan. I'm an academic at the University of Otago, and I had the great pleasure last year of working with the Helen Clark Foundation on this project. The full reports are available online, and today I'm just going to focus on some of the key findings, particularly in relation to harm reduction. So the aim of this project was to understand the views of New Zealanders on how the government responds to illegal drugs, by firstly providing an estimate of how the government spends its money now responding to drug issues, then determining whether that current allocation is consistent with what the public would like, how they would like the money spent from a polling data, and then using a deliberative workshop method with a group of citizens to better understand people's views. So how do we spend our money now? When we look across the 4 policy areas, so this is reducing supply, so things like customs, policing, prisons, treatment, which is within the health system for people experiencing harmful use, prevention, which is aimed at stopping drug use from starting, and harm reduction, which is aimed at reducing harm for people who use drugs, you can see that there is a very uneven split between those 4 areas, and most of the money goes to law enforcement and reducing supply. Harm reduction only receives 1.4% of the current money spent in New Zealand. So to put that into context, that was 489 million in 2022-23 for the entire drug budget, or 0.3% of Crown expenditure, $95 per person, and harm reduction is only getting 1.4% of that, compared to estimated harm of almost $2 billion annually. So how does the community then want their tax spent? Well, to answer this question, I conducted a nationwide stratified poll, and we asked the question, if $100 of the tax that you pay each year was being used by the government to respond to illegal drugs, how would you actually like it to be split between those 4 different policy areas? And what we found is that the way that the public wants the money spent is very different from the actualities. And you can see that harm reduction, people allocated 16% of their theoretical $100 to harm reduction compared to 1.4% actual. And supply reduction falls from 68% of the actual to only being given just over a third, or 36% of the public's allocation. When we look at these findings by political preferences, we see that there are some differences, but still the amount of money allocated to harm reduction is much more than what is allocated now. So whilst those who voted for parties in the current government coalition allocated less to harm reduction, so just over 10%, as opposed to people who voted for those in the opposition bloc, it was still substantially more than the 1.4% of actual spending. And this indicates that there's great support for harm reduction that exists across party lines. So if there is this big disconnect between actual spending and community views, how can this be bridged? So I use deliberative workshops as a means of exploring people's views and what happens when they learnt more about drugs and drug issues. So to do this, I met 7 times last year with 10 retirees from a U3A group in Christchurch. And we had expert presentations plus discussion and readings on all these different topic areas related to drugs and drug policy. But the agenda for this was set by the participants, and they were the ones who really reinforced to me what they wanted to learn and what they wanted to talk about. And what this group chose to do with this knowledge was to produce a consensus statement, which is available in full in the report, but highlighting some of the harm reduction aspects. Firstly, the group thought that there should be an overall move towards a health-based approach to drug use in New Zealand, and that greater investment in harm reduction was required to support that. They also asserted that harm reduction really needs to be publicised more to increase public knowledge, because they felt that that was the area of drug policy that they knew the least about, and that any changes to drug policy had to be developed with strong and appropriate engagement with the communities that are most impacted by drug harm, including Māori and Pacifica communities. So the conclusion of this report was that there's this disconnect between community preferences and current drug policy funding, and that there is strong public support for increasing funding for a health-based approach, particularly for harm reduction, and politicians therefore have a lot of room to move. So these are the full recommendations from the report, but focusing on those particularly relevant to harm reduction. Firstly, that the government should immediately increase funding for prevention, treatment and harm reduction in New Zealand, but that the government should also develop, implement and comprehensively fund an evidence-based harm reduction program for New Zealand. So rather than just sort of piecemeal bits of funding here and there for different programs, there should be an overarching strategy and alignment with international best practice to reduce harm for people who use drugs in Aotearoa, New Zealand. Thank you.
Thank you very much, Rose. That was a great summary. You know, there's always an issue, even when there is harm reduction, in enabling people to access it if their behaviour is stigmatised and illegal. That was indeed an insight which drove Parliament to decriminalise men having sex with men in the mid-1980s, because we couldn't tackle the AIDS pandemic while male homosexuality was illegal. And we run into the same issues, I think, with harm reduction in the case of people who use drugs. If their behaviour is criminalised, then there's a stigma. Harder to access services. You may only even get to a service when you're first apprehended by police or even in jail. There was, under the previous government, a very important change to the law, which was the Misuse of Drugs Act amendment, which gave the police a directive not to arrest or prosecute unless it was in the public interest, when they apprehended a person who was using drugs. And the whole idea was to be able to divert to services. Unfortunately, a lot of the services weren't there, and I'm told that perhaps the arresting and conviction rates are going up again in the current political context in any case. So that's part of this bigger picture around access to harm reduction. But on our call, there may be those that are thinking, well, hang on, could everyone explain what harm reduction is? So I'm going to bring in Sarah for a broad definition from New Zealand, and Esther for a broad definition from Canada. And after that, I'd like to come back to you, Esther and Sarah, and we want to spend a little bit of time on the voices of Indigenous people and approaches around harm reduction as well. And I'll bring you back in too, Rose. So Sarah, a broad definition of harm reduction for our audience.
Yeah, I'd say harm reduction prioritises positive change and the well-being of people over other things. And so, for example, taking a very non-judgmental approach and offering people things that will reduce their harm or create better outcomes, rather than trying to force things like abstinence. It doesn't preclude abstinence, but it's not focused on making people stop or reduce their use necessarily. And I think it's really important for this to take a non-judgmental approach, because otherwise people choose not to engage. So you can imagine if people were coming in for drug checking, as we have legalised in New Zealand, and they received a lecture along with their testing of their substance, they might choose not to come again, and that might result in fatalities. And really important in New Zealand is we worked with Kiri Opai, an expert linguist here, to come up with a Māori term for harm reduction, whakaiti pā mamai kai whakapiri. And part of the point of that was to really understand a Māori point of view from about harm reduction, and that it's not just a Western recent thing. And in fact, we would say that Māori helped to create harm reduction here in Aotearoa, New Zealand, over 100 years ago with the creation of the Māori Wardens, which are a group of Māori-led organisation that helps to support people who are having issues with alcohol out on the street. So, yeah, thank you.
Yes, totally agree with what you say, that services need to meet people where they are. In the middle of 2024, I went to Glasgow, which has the first in the UK safer consumption site. And these are well established, of course, in Sydney, Melbourne, parts of Canada, although under pressure there, and across much of Western Europe. But the idea is that you can walk off the street with your drugs that you've purchased on the street. The drugs can be tested, and Glasgow, since I visited, has now got a license for that as well. And then people consume under supervision, and there's no questions asked. And the police don't hang around the door to arrest people as they walk in and out. That's not the aim of it. The aim of it is to keep people alive and safe. Now, over time, as you build up confidence, of course, some people will opt to go into more mainline NHS services. And right next to this facility in Glasgow is actually a legal heroin injection site where people are supported there, but without the low threshold entry to the safer consumption room, you wouldn't get them through that other door. So, Esther, let me come to you in the Canadian context on harm reduction. I know there's been some ups and downs with the current provincial government in Ontario, for example, starting to defund sites, and some ups and downs in British Columbia as well, which had been quite forward-leaning. But we're really, really very eager to hear your perspective.
Thank you, Helen. I hope you guys can hear me.
Very well. Very
okay, good. I'm at a roadside stop here, so I hope we're not interrupted. But I am from the Blackfoot Confederacy, Ghana or Kainai from the Blackfoot Confederacy, and our reserve is a very large reserve in Canada, which has approximately 13,000 people or members on reserve. And we still practice our ways quite well. And now there's been a renaissance of Blackfoot language and ways, because that is part of the trauma that's led to where we're at. But we were forced into finding new ways to address the mortality rate that we were seeing. So in our Blackfoot ways, we have a term already that's called Gimmat Bitsin. And there is actually a film that my daughter made. It's called Gimmat Bitsin, about the meaning of empathy that our people have for each other. And Blood Reserve or Canada was hit with fentanyl in 2014. It was very new across the country. Most Indigenous communities were insulated from it in the beginning, but we were hit very, very hard with it. And we had many, many deaths in the beginning, and we had to find a way to help save lives. And so we took a look at harm reduction and what harm reduction really means. And for us, it was the beginning of saving lives. So some of the things that we have embraced is, number one, we taught our people CPR, and we taught our people how to use naloxone, and we adopted naloxone kits when it was not legal in most places for lay people to actually use naloxone. but we had so many deaths that we had to start somewhere. And the discussion in our community is, aren't you just enabling them to continue? And so among our community members, we had a lot of discussion, but one of the things that was said is you cannot enable a dead body. And from that point on, our people began to embrace harm reduction, the beginning of that being the use of naloxone. In March of 2015, when we did a community-wide blitz in teaching and providing naloxone, we had 0 deaths for 3 months. So we know that that harm reduction is and does save lives. We also know that what's attached to that are a number of other things as well, and one of them is infectious diseases. We've seen a huge rise in syphilis, and for a long time never had any babies born to syphilis, but we have that now in the province. We had low numbers of HIV. Our HIV numbers were on the rise. And of course, Hep C it was not prevalent, but now is very prevalent. And so we also embrace other parts of harm reduction, such as safe sex, making sure we're handing out safe and clean syringes and condoms, and teaching people about how to use that, because the consequences of that is we have babies that are born in syphilis if we're not careful, and have a number of babies also born into HIV. So harm reduction embraces all of that. It's not only saving lives, but saving our population from the impact of what goes along with it. So many things to discuss about it, but we have embraced harm reduction. Our province, initially we had an NDP government that actually really supported harm reduction and helped us to do the learning and to get the supplies, and instituted the first safe consumption sites in the province, one which is very close to our my reserve. In 2019, the government changed to a conservative government, the United Conservative Party of Alberta, and they began to reduce all of the supports for the safe consumption site and for harm reduction. So the safe consumption site in Lethbridge closed in 2019, and as a result, our mortality rate skyrocketed. So at one time, we were almost double the mortality rate of non-Indigenous people in the province due to drug overdose, and now we're 7 times higher. And that was a result of policy change in the province. Anyway, I'll answer other questions. I'm going to give you a chance to discuss.
Well, thank you very much, Esther. It's inspirational what you said about how the Confederation, picked up the issue and adopted a comprehensive approach, but devastating also to hear the consequences of a change of government winding back on what it's possible to do. I might bring Rose back in and say to you, Rose, when you were discussing the issues with the retirees at U3A, was it your understanding that they grasped really how critical this was to life and health to have these kinds of services available?
Yes, I think that they really the harm reduction conversation and the speaker that came to the group who had lived experience of drug use and drug harm really resonated for people. And it was interesting, the conversation was quite different in that session, because I think that the group had a sort of a lower baseline understanding. Some of them hadn't even really heard the term harm reduction before. And so they went into the conversation not really knowing what harm reduction meant or what it could do. And yet that discussion was incredibly rich and rewarding. And one of the conclusions that they reached in their consensus statement was that harm reduction is actually really important, but that it's perhaps misunderstood or poorly understood by the community. So they were saying, well, yes, sure, we should increase funding, but we also need to just help people understand what harm reduction is and does, because then people will support it more. And I think that whole process, what it taught me, and what I think it was valuable for, was that people's views really changed the more that they learnt about drugs. So this was a group who, didn't, they were a group of retirees from Riccarton, and they didn't necessarily know a lot about drugs and drug policy, but they produced this consensus statement because they had had a chance to learn and discuss. And the conclusions they reached was that harm reduction is vital.
Yes, I often say to people, well, harm reduction may mean that your parent, your child, your sister, your uncle, your cousin actually lives when they might otherwise have died. And regardless of the choices people make about their lives and what they consume, I assume nobody actually wants them dead because of those choices. That's why drug testing in New Zealand was so important, because we, ran the real risk of young people buying drugs from those they didn't usually buy from at festivals, not knowing what they're buying and dying as a result. And with the, growing presence of synthetics in the drug mix around the world, this is becoming a huge threat. Sarah, listening to Rose and to Esther's very important points, where are we on the spectrum in New Zealand? You mentioned the drug testing, which absolutely terrific that New Zealand became the first country in the world to actually have legislation legalising drug checking. But we have no safer consumption rooms here. It's very much the traditional getting on a public health waiting list for what we used to call methadone maintenance. Now we call opioid substitution therapy. What about availability of naloxone where it's likely to be used? Where are we at in New Zealand on the spectrum of what we need to do?
Yeah, on the one hand, we can be very proud of the measures we do have in place. So, of course, the needle exchange, legalisation and creation in the late 1980s, and the legalisation of both drug checking, so testing people's substances, and actually not only at festivals, we're out doing it in the community all the time. So that combined with an early warning system that's supported by the government and has civil society or NGO partners who have more relationships with people who use drugs like ourselves. Those things combined are providing quite an important protection against the toxicity and the volume of the drug supply problems that we're seeing globally and domestically. It is no small thing to say that we are seeing a terrifying tsunami of a really diversified, potent, and increased drug supply coming across the border. And it's not just here, that is just a reflection of what's happening around the world. So you would think with those wonderful feathers in our bow, we would then not have any hesitation about doing other things, but actually it's very hard to get other harm reduction in place. And as you've pointed out, we don't have safer consumption rooms. We don't have wider distribution of other safe using utensils. We have patchy naloxone availability. We only have the injecting ampule type naloxone. We don't have the nasal spray readily available here. That is a very long story, but anyway. And also we're operating our harm reduction services that we do have in a very, very punitive legislative framework. So we legalised drug checking, but as an amendment to our Misuse of Drugs Act. And that wider legislation is very prohibitive and very criminal oriented. And so it's very, very hard to make any gains under that framework. Yeah.
Yeah, so brings back so many memories. My government, of course, charged Sir Geoffrey Palmer and the Law Commission with reviewing the Misuse of Drugs Act. It was impossible to make any movement at the time politically on moving away from prohibition because there weren't the votes for it in Parliament. But anyway, the Law Commission then delivered the report in the time of the Key government and recommended a total rewrite of the Misuse of Drugs Act to reflect the need for a health and human rights and harm reduction based approach, that review never happened. You're right to remind us, Sarah, that New Zealand also was first in establishing a public needle exchange scheme in 1987. So we've had our bits of pioneering, but then we kind of stall, as you say. And because we're stalled, we're particularly vulnerable to the wave of synthetics coming down the track. We were advised by experts at our Global Commission on Drug Policy meeting last year that there's no law enforcement response to the synthetics. There's so many dual-use chemicals. You can only combat synthetics and the damage they may do people with a massive harm reduction approach, and we're not there yet, obviously. Just a quick question to you, Sarah. How does our drug-related death rate compare with, say, Australia, Europe, UK? UK is pretty bad, and Scotland has the worst in all of Western Europe. But where do we sit on that spectrum?
I'm not sure if I know where we rank globally, but what I can say is we lose about 3 New Zealanders every week to entirely preventable unintentional overdose. And that compares really poorly to other statistics that we measure ourselves against, like drownings. It's about twice the number of drownings, or the road toll. It's over half, it equates to over half of the road toll. So we're talking a significant number of New Zealanders whose lives could be otherwise, saved by really good, because that's the other thing we're behind on, is overdose measures here.
Yeah. Well, that is a disturbing figure and quite high, and as you say, completely preventable. So again, makes the case for change. Esther, coming back to you. Firstly, I have followed politics in Alberta a little bit. When I was in Alberta around about 2018, I met, was it Rachel Notley, who was the Premier at the time, the New Democratic Party Premier, and she's a marvellous human being. But I understand the norm has been to have quite conservative governments in Alberta. What hope is there for what you would really like to achieve in this political context, not only in Alberta, but also now looking at the rollback in Ontario and some of the squeamishness in British Columbia about some of the braver moves that they had made? So any reflections on this, and what New Zealand needs to avoid from the Canadian experience, but also what are the positives we could pick up?
One of the things that I know that what's most important is human life, and that's what we're talking about right now, is the importance of human life. But when you're speaking to conservative governments, it always has to be about money and return on investment. And so the conversation needs to be about, if you don't save this life, or you don't intervene and help a person who needs help, there's so many repercussions. One is the health of that one individual. I have a patient I call the $1 million man, who this was alcohol though, but he actually fell and had a subdural hematoma a few years ago. He had to be ambulance or starlifted by air to Calgary. Neurosurgeon spent some time with him in the OR, and then he spent time in the ICU and subsequently rehab. And a week after he returned, he had a second fall and subdural hematoma. And the third time, he ended up in a nursing home and is in a nursing home now. But when my colleagues and I added up the cost of that one individual not being helped, it was over $1 million. And if we had had supportive housing, and if we had helped this person in the space that he was in, I'm sure it would have cost not even a tenth of what that $1 million was. So that's one thing. And the other thing is the cost and the burden on a healthcare system in terms of emergency room visits, the surgeries that need to take place, the hospitalizations, all of the cost to the healthcare system is overwhelming. And, you know, if we're not actually talking human lives, but the overwhelming burden to the system, and if we don't intervene in the proper way. So I think the conversation for conservative governments is about return on investment. If we invest in these people's lives at an early stage, we will be preventing the system a lot of money in later stages. And not to even mention the childcare issues that we have now, and that's orphaned children who are in our foster care system and then the trauma that they have while they're in the system, and when they age out, they are the second generation of unhoused on the street in a second generation, third generation type of toxic drug supply. So it's going to continue unless we start looking at it at a overall uh, um, strategy on how we're going to do this. And it does cost money not to do something.
Mm. And there's a particular and traumatic history in Alberta, is there not, around the children taken into care, Indigenous children taken into care, and huge grief, loss of culture. And we're not just talking 19th century, we're talking right up to relatively modern times. And if this is now an issue that children are losing their parents in your communities, where do these children go? Who's caring for them? What happens to them as Indigenous children? Any comments on that?
I think it's also a new generation of ACEs, or adverse childhood events, that we're seeing. So the first generation being all of the people who went to residential school. And we know that the ACEs are a way of scoring trauma in all people, and that would be scoring child abuse, physical, mental, or emotional, and sexual, and then abandonment issues, as well as what is going on in the household. So the scores of residential school children, or people that have been to residential school, are usually pretty high to 10, and that correlates with high chronic disease, high mental illness, addictions, and often suicide. So we're seeing a second generation of this same type of thing, but in foster care, and the disconnect that children feel from their community, from their language, and from their people. And it's very, very hard for them to reconnect. But the consequences of that we are about to see.
Yeah, very, very, very concerning indeed, and shows the interconnection of all these issues. Sarah, putting on your hat as a descendant of Kaitahu, Kati Mamoi, and Waitaha, any points to be made around Indigenous approaches here, and how they might relate to some of the issues that Esther's raising?
I think both in our work here in Aotearoa, New Zealand, and internationally, we hear really common stories, as Esther was just describing, in our other colonised populations. So for Māori, for Indigenous people in Australia, across the Americas, etc. And so we're facing really similar things in terms of some of the issues both that led people into substance use, and some of the responses to substance harm. So, for example, here Māori face disproportionate outcomes. I think it's double the overdose fatality rate of non-Māori, and 50% higher imprisonment rate for drug offences in 2023, for example. So really worse outcomes on all scores.
I'm also remembering that a couple of years ago, when the Helen Clark Foundation and the Drug Foundation did the report on Te Ara Oranga, which was piloted in Whangarei to support harm reduction for people using methamphetamine, we had on our webinar people from the Arctic University of Norway, and they related very common experiences to what we're discussing now with respect to Māori and to Indigenous Canadians from Indigenous Sami in the Arctic territories. So I think the work you're doing, Sarah and Esther, to give visibility to the Indigenous perspectives and how these issues are intruding on and damaging culture, identity, etc., is very, very important. Now we've got some great questions in the chat box. I'm just going to bring them up. Excuse me, looking like I'm fiddling with the screen here. So we have a couple to you, Rose, around. I mean, you didn't seek out to have a representative sample for the exercise that you did, but what people are asking, can you generalize, do you think, from the University of the Third Age retirees to acceptability of harm reduction across the society? Are you planning to take the research any further than where it went so far?
Yeah, that's a great question. So the poll itself was nationally representative. We had, very good demographic coverage from the polling data. The deliberative workshops were never intended to be representative because just of the size and the scale of the task. What I was really interested in, though, was how people's views change through learning. And so for that reason, I was interested in a group of people who were interested in learning, which is what U3A is set up to do. And I also thought that doing this project with retirees would be really interesting because that would be a group of people whose views might be quite entrenched, or they might have strong views about drugs. And it turns out they did, but they were still very open to learning more and to discussing and to changing their minds through learning. And I would be really interested in doing that part of that research more with different groups of people and understanding, how people's minds change, and what helps change people's minds. But ultimately, what that led me to conclude was that we actually need to have a wider deliberative process in New Zealand, something like a citizens' assembly on drugs, similar to what Ireland has done in the last couple of years, because people learn through discussion and through hearing from others with lived experience, and we're sort of missing that in our debate. Our public debate gets very binary. This is a way of making it nuanced, and I think that's really valuable.
Yes, I think what you say has real merit. I'm also inclined to observe and not likely that if the demographic that you were working with in your study, which is basically my demographic, if you're able to change the minds of older demographics on it, then the chances are that the younger ones might also be receptive, if not more so. And the idea of having citizen jury approach, citizen assembly approach is extremely interesting. Kate McKevitt's asking us to explore a little bit more using the drugs in a supervised environment. She says, I know the spaces save lives and it should be encouraged, but how is it balanced in terms of getting the general community on board, particularly with where the facilities are built? And Kate references Melbourne, for example, where there was some discomfort with placement of the injection room. Kate, I went to the Melbourne Centre, which is run by the Victorian State Government. Terrific centre, state of the art, no questions asked, people come in with their drugs. Actually, what people were faced with in the neighbourhood before was stepping over dead bodies from people who were consuming with no access to harm reduction. So while, of course, there was pushback and almost inevitably will be and has been with respect to the next site, I understand it was being discussed, in the end, it is life-saving and it does take the consumption off the streets. There's still the issue, of course, of the sales being on the street, and some of the braver safer consumption room initiatives have piloted a safer supply as well, where the drug is available on the premise. But not a lot have gone down that track. Kate, Esther, any comments you'd like to make about acceptability within communities? I think, Esther, within your community, what I was hearing very much was that people just want to see their relatives' lives saved. So I assume that the harm reduction was very much acceptable where you were working.
Yes, I think we've had a lot of those conversations as well. And I think it's because harm reduction shouldn't be seen alone in the whole spectrum of the work that needs to be done. And that's what happens a lot of times is a safe consumption site or the harm reduction work is isolated away from everything else. And what we really need to do is show a whole continuum of care where we save lives and take them from or offer in the same area a detox where they have where they can decide, okay, I'm done. It's time to go to detox. And we have a supportive medical detox where they know that they're going to get supportive care. And from the detox, we have pre-treatment and treatment centers that are supportive of opiate replacement therapy and other therapies that are needed, and also recognizing now that many of the people going into treatment have other mental health issues that we really need to start including in our treatment. And we have aftercare and supportive housing. So what we need to do is make sure that we don't see it in an isolated way. It's a part of a whole system. It's basically, we look at going to the emergency room for care, but you may need to be admitted to hospital. Let's say you have because we see, and most people see opiate use disorder or polysubstance use disorder as a medical issue and not a criminal or a justice issue. And so you wouldn't do that to a diabetic where you would deny them the care that they need. You wouldn't do that to somebody that has hypertension and is on the verge of a stroke. You wouldn't turn your head the other way. But because we moralize addictions and we moralize that, we turn our head the other way. And so harm reduction shouldn't be isolated from a whole spectrum of care that's needed for this medical issue. And I think that's what we do is we tend to be discussing just that one part of the help that people need.
Yeah, no, absolutely a fair point. At the Melbourne Victorian State Government facility, it's interesting that once they have people's confidence, people start being tested for HIV, sexually transmitted diseases in general, hepatitis B, get the dental care and other things attended to. So it may be the safer consumption which draws them to the centre, but then providing the other services has become very important as well. Tom Avery asks us, we must work on depoliticising harm reduction to secure consistent investment as possible and reframe it as a pragmatic public health and economic issue rather than a moral or political one. Sarah, how are we doing on this in New Zealand? I mean, it's a no-brainer, as we've already said in this webinar, and I think Esther made the point that harm reduction is the stitch in time that saves 9. So how do we get across the pragmatic case that this works and is cost effective?
It's absolutely. In fact, that's our one of our strategic goals is depoliticising drug issues and trying to move away from that very partisan, divisive approach, or even liberal versus conservative, etc. And we have a wee way to go. So I would say, a bit like Rose's research has pointed out, and other little data points, that the public and the media seem to really understand harm reduction and really get it and have been supportive of it for a long time. They might not understand the terminology, but when you start describing what it is, there's really strong support. We've had years now of talking about the results of drug checking and the early warning system in the public domain, and it's really helped to inform the public around the different risks of substances worse than the ones that the Misuse of Drugs Act were created to control. So I think there's a really good understanding and support for change. It's the political side of things that can be difficult. But even then, we're making incremental change. And so we'd rather see wholesale change, of course. I think that the best thing we could possibly do is replace the Misuse of Drugs Act with a piece of legislation that actually centres the health and well-being of people rather than taking a purely punitive approach. And we did some work on that late last year. Now, actually, when we released our Safer Drug Laws report, which looked at the evidence worldwide, we talked to Māori leaders here, and we tried to come up with what might be the most evidence-based legislative framework. We were met with resounding support across all sides of media and society. We had some at the right-wing commentariat saying, isn't the Drug Foundation just saying what we know already needs to happen? And so that really, for me, helped to underline that society's actually already arrived at the understanding. It's getting it through politically or through government that the change really needs to happen at this point.
And of course, we have an election year, which is an opportunity to raise these issues as politicians and parties seek our votes. So I would encourage people, and maybe we can put in the chat the model drug law, which the New Zealand Drug Foundation has developed as a way of reforming the overall approach through the law in New Zealand. Rose, Judy Blakey asks, have you had any discussions with the researchers from the Dunedin longitudinal study in relation to drug consumption and opportunities to explore harm reduction? Actually, did I not read that study's funding was threatened after so many years and such a valuable research exercise? But I'll bring you back in, Rose.
So I haven't worked with the Dunedin study, no, but I work quite frequently with the Christchurch Health and Development study. So they're a similar study, but their participants are just very slightly young. I think they're about 5 years younger. And I work a lot with Professor Joe Bowden, who is the principal scientist on that study. That study really highlights, for me, from a public health perspective, it really highlights that we shouldn't apply a moral judgment to people who use drugs, right? There is a lot of data from that study that tells us the types of things that are associated with drug use in as teenagers and as adults. And it's things like exposure to childhood trauma and poverty and abuse. And so that really highlights for me that a lot of opportunities for reducing drug harm more broadly lie back with those social determinants of health and give us the ways in which we can understand drug use as, not as a moral failing or as just a result of poor choices. So I think those longitudinal studies have a lot to offer us in terms of understanding drug use. Also noting, of course, that drug use is not just a young person issue, and that those cohorts are now into their late 40s and 50s and present us with a really good opportunity to understand drug use in an aging population and have great insights.
Thank you, Rose, and that I think very much answers Grace Southern's question about paying attention to the reasons why that all the needs that drugs are addressing. It sort of gets back into those whole social determinants. I know we're coming reasonably close to the end, so I'm going to ask each of the panelists what they'd like their governments to do now as next and important steps on harm reduction approach to drugs. I'll bring you back in, Esther. I can almost anticipate that you will say that you actually had something that was working, it was snatched away. But what should they be doing now in Alberta?
I think they should be re-examining the impact of negative policy on human beings and how it impacts first the family and then the society and the communities that we have. We have elderly people or elders in their 70s and 80s who are raising young children because of the loss of their parents. And so we have households of people who are 17, 18 people per 3-bedroom household, and grandparents who are trying to stretch the stew and bannock or the soup and bread to feed all of the people in their homes. So there has to be a new look at this, and the moralization for a small group of people does not make sense when it comes to a large population of people who are suffering.
Thank you so much, Esther. Really wishing you well and trying to, get the politicians to take a pragmatic approach in your province and just not moralise and stigmatise, which is clearly so damaging to people's lives and health. Sarah, what do you want to put on the agenda for our campaign this year? What do you want governments to do as their first big new step on harm reduction?
I think just to preface it, I think really we do need to leave behind the moral focus on drug use. I think one of the reasons is not only those social determinants of health, but actually unmet health need driving drug use and substance use disorder. For example, ADHD, but actually I think the evidence is increasingly pointing to other health issues that might be one of some of the reasons why people are using substances we've chosen to make illegal. And so off the back of that, I think we would really like to see our Misuse of Drugs Act, which is over 50 years old, repealed and replaced. We have spelt out what we think would be a good replacement for it based on the evidence, and that is removing criminal penalties for use, greatly increasing the investment in treatment and harm reduction alongside that criminal penalty removal, because actually that helps to increase the benefit of that. And some of the other measures might be, allowing for non-profit sharing of cannabis and looking at some other ways of regulating substances as the evidence comes to light. But one of the more important parts in that for harm reduction is actually just legalising harm reduction. We would really like to see a licensing system for harm reduction so that we don't have to go through legislative change every time we want to see a new harm reduction measure put in place. Goodness knows what awaits us even tomorrow in terms of the substances coming in into the country. And so we need to be able to be more responsive and put in overdose prevention and harm reduction measures as they're needed.
Our public health capacity has been pretty savagely cut, as I understand it, in New Zealand. Do we have within our public system now the expertise which could drive forward on this if politicians come forward and say we want to move? Are we capacitated to take these important steps right now?
It's a good question. I think there is still the expertise in and out of government to be able to move forward on these things, but it does require more resourcing to do it properly anyway. Yeah.
And Rose, bring you in. What would you like most? Citizens Assembly? Or
yes, well, yeah, definitely. I mean, obviously the recommendations in the report, including the Citizens Assembly, and I agree with all of Sarah's comments, but actually I think there's one thing to add to those, which is that the key principle of harm reduction is that it is led by and for people who use drugs. And at the moment, we've just got a really poor connectivity with people who use drugs and uplifting their needs and actually building from their lived experience. So what I'd do, if I had the ability to change something today, it would be for government to fund an organisation like AVIL in Australia, which is a peak body that represents the needs and voices of people who use drugs, and it's peer-led. And so it's a way of bringing lived experience to the policy table and centering and uplifting people's voices. That would be my wish for today.
That would be terrific. Thank you so much. In the comments, someone, Christine, mentions that Esther referenced a film on compassion by her daughter on drug harm reduction, and asks, is it available for viewing? So I think, Carly, when we send out the webinar link for people, it would be good to put a reference to that film on it so others can get benefit from it. Absolutely terrific panel. Thank you so much. Carly, I'm going to hand back to you.
Yeah, fantastic. Thank you so much for that amazing talk. I was on the edge of my seat. That was great. Thank you, Helen, for moderating. I think it was a really ultimately very hopeful talk, and it's great to hear. We have all the solutions. We just need a bit of political bravery. So let's encourage our politicians to be brave and to make this an issue as part of the upcoming election as well. Thank you so much to all of you, and thank you as well to our audience for joining today and for your fantastic comments and insights. We hope you got a lot out of it. Don't forget, we have you can walk away with a classy tote bag if you join up to be a Helen Clark Foundation member today. So please do think about doing that. Otherwise, we look forward to seeing you soon, and have a great day, everybody.